So we'd like to jump right into our first panel of the day. So invite them to the stage. Discussing the future of cyber and healthcare, health information systems must support the latest security technology to detect threats and protect sensitive personal health information while continuing to adapt. Our panelists today will discuss this delicate balance between security and innovation and how they're implementing security technologies such as Zero Trust and ICAM. Welcome, Mr. Conrad Belvell, Colonel Joe Hoffard, and Mr. Woody Robinson. Over to our moderator, Mr. Matt Hayden, Vice President for Cyber Client Engagement at GDIT. Over to you, Matt.
Thank you so much. It's really a pleasure to get to follow up on two great presentations. You hear both from the technologists and from Dr. Clancy about the great advantages we have at our feet. We also have the challenge of protecting what we have and protecting as we bring these things forward. So rather than waste another minute, I want to jump into really working with these practitioners we do have on stage. One of the big challenges that befalls all of you is that you run large systems that millions of people rely on. What we'll do is to start with introducing yourself and just kind of give an idea of where you are to protect those systems.
Okay. Good afternoon. My name is Conrad Belvell. I'm with the Center for Medicaid and Medicaid Services. My official title, Director, Division of Information System Security. I'm the security lead for a system called HighGlass. That system processes, $1.6 trillion a year. That's trillion, because all Medicaid, Medicare, CHIP, Affordable Care Act, and other grants and programs that CMS manages runs through my system. So my objective in life is to not make the Washington Post. Because I don't want to be that guy. So there's a methodology and approach that we apply to protect that information. And it's one that was actually born in my effort as I'm a retired Army warrant officer and did a lot of things with the Army ACERT and look at things at the bit level and did a lot of red team and blue team things. So we developed our SOC based on the premise that someone had broken into our network, and it was up to the team to convince me that they aren't there. Because no matter what, that individual who is in there is going to have to try to get out, and they need to provide me evidence that there is no activity consistent with compromise. So every morning at 9:30, there's a security briefing. It's not a PowerPoint thing. It's done on monitors with looking at dashboards and the like that tell the story of security. Because again, I cannot fail. That's one of the things that everyone at the organization has impressed upon us, that the payments must be made. My parents are Medicare recipients. I've got skin in the game. So it's not a notional exercise. But there's a tremendous amount of work and a lot of brain power that's brought to bear. And we have an approach that says security is a business enabler. And why is that? Because I've been on the CIO side where, let's just say, I said no a lot. Then go on the business side and we have to get to yes. And with good security practices employed, you can get to yes. You can deliver capabilities in a secure fashion. Our narrative is, how do we support the secure execution of mission? We don't do security for security's sake. We're doing it to facilitate delivery of services to those in need. So it's something we take very seriously, and I'm no longer Captain No. It's yes if. Yes if. It's a business decision. You got the money, we can make it happen.
Colonel Hoffard.
All right, hi, I'm Colonel Joe Hoffard. I have 5 hats at Defense Health Agency. I'm the Deputy PEO of Medical Systems, the Chief of Solution Delivery Division, the Chief of Risk Management Executive Division, Principal AODR, and the CISO for the CISO. We call it CISO in the Department of Defense because we have to be fancy. So you put a senior in the front instead of chief, but it's the same thing as a CISO. So we operate the 4th largest network in the Department of Defense, 320,000 endpoints. And it's my responsibility to identify, protect, defend that network. All of the NIST cybersecurity framework fundamentals fall under my purview as the CISO for DHA. And so we're kind of unique in the DoD that in any other operational unit anywhere else in the DoD, your keys to your kingdom would be kept on the SIPRNet or on JWIX or on some higher level platform that is isolated from the general internet. It's completely separate and much more secure than the unclassified network. Well, as you can tell from the partners up here, we can't do that. That's not something you can do with healthcare data. It has to be accessible and shareable because the goal at the end of the day isn't to close with and destroy the enemy. It is to ensure a medically ready force and a ready medical force for the nation and to care for our veterans from cradle to grave and their families from cradle to grave. And because we have that charge, we have to protect some of the most sensitive information out there. So on the dark web, credit card information sell for about $10. Your personal health information will sell for several thousand, right? Because it's immutable, right? It's not something that you can go in and change. You compromise my credit card, you may make a single charge, and then I get a new credit card. I dispute the charge, and there's no harm, no foul. But as a criminal, you may have got that. But if I'm the Secretary of Defense, and you get my medical record, and you discover that I have gonorrhea persiflage, you could. That was supposed to be funny. You could. That's not a true statement, by the way. I would just. You discover that I have the gonorrhea persiflage. That the blackmail that's involved with that, exposing that to the nation, things like that. That's huge, right? And if I had that disease, it's not like I could go and undo that and change it, right? So, PHI is our keys to the kingdom. We have a single medical network that defends that. We have our Cyber Operations Center that's operated by the Naval Information Warfare Center. There are partners in that. There are partners in a lot of different endeavors that we do in Defense Health Agency. And I'm happy to report that my background's Army, obviously Army Medicine. I was also at Army Cyber Command. I ran the cyber inspections program for the Army, the larger Army, not Army Medicine. And our inspection scores on the MedCoy and on our CSSP are better than anything I saw anywhere in the rest of DoD. And so my confidence level that we are doing as much as we can to defend that PHI from adversaries, from those adversaries being everything from somebody on their phone playing around with a new script they found on the dark web to a nation-state actor. I think we've done a fairly good job of putting those controls in place. But to your point, you can't defend it so hard that the data is not accessible to those folks that need it, right? So it's always a balancing act.
All right, Woody?
All right. Totally agree. It's definitely a balancing act, and it's a difficult act sometimes, isn't it? So Woody Robinson, I'm with the Department of Veterans Affairs. I am the Specialized Device Cybersecurity Director. I have one job. These guys have about 4 or 5. I have one job. But I support a multitude of systems across VA, special purpose systems, the Internet of Things, medical devices, but also telehealth systems, which is, as we all know, is growing continuously in support of healthcare services. So one of the things that we do is making sure that those devices, those systems are secure and protected. And that's not always easy because we have to contend with what? FDA regulations and other guidances that says thou shalt not do, thou should not do this, do that, etc. So what we have to ensure is, and what we do within the VA is make sure those devices are isolated, segmented. We make sure we have the proper security controls in place and solutions to be able to monitor and analyze those devices, analyze the traffic to see if there's any anomalies within that traffic. Some of the things that we've encountered is just making sure we understand what are the vulnerabilities for these devices. That is a challenge. Understanding the vulnerabilities and understanding how do we work with our industry partners, which we do, but it's still challenging at times. But how do we work with those industry partners to better understand or better insert cybersecurity in development stages for these devices? So we work hand in hand across various partners to make sure we understand this. We also, one of the other things that we work within the VA is just understanding how we outline, how do we protect our infrastructure. And with that, we really have adopted and embraced Zero Trust architecture. We find that Zero Trust architecture is really the bread and butter for us in making sure that we protect these systems and devices within our ecosystem. Besides that, that's it.
All right.
Yeah.
Well, Woody, I'll pick on you because you did just say that you deal in all these devices. And in the nature of healthcare being so dynamic, as we see the change in not just the technologies that come through the door from an innovation standpoint, but the requirements of their use, how is your organization dealing with those new items, those innovations that come to your doorstep?
That's a very good question. One of the things that we're doing and we have adopted, and it's really, we're taking a page from the Zero Trust again, is what we have is a strategic plan, a Zero Trust strategic plan, where we make sure that we analyze and assess those devices. We make sure the proper security controls are in place to support those devices. But more importantly, we make sure we have the proper infrastructures in place and security solutions to be able to detect, respond, et cetera. So that's some of the things that we're doing with those innovations.
All right, and Conrad Belvell.
Yeah, and there's multiple different ways we're approaching this. One is that we are getting a much better handle on who is allowed to do innovations and where, right? So that you have greater control over those one-off shops that are out there and putting stuff on the network that could potentially compromise the entire MedCoy. And the way we're able to do that is it's a one big network, right? So it's one big network with a single authorizing official, Mr. Pat Flanders, that everything gets authorized to be on that network. And it starts with baking that in from the very beginning in those centers that are actually doing that innovation. And ensuring that from the very start of any development effort, you've considered the cybersecurity ramifications of that and what that looks like. And I say that on this side, and then on this side, what we often get are these Christmas presents that show up, right? Where someone has, oh, look what I brought you. And it's a brand new shiny thing that somebody bought, maybe 3 or 4 people before them, and it shows up on the loading dock. And so the big shift in our organization that happened with risk management framework, and not to go too far down that rabbit hole, is the fact that you go from a compliance-based cybersecurity approach to a risk-based cybersecurity approach. And you look at all these innovations through the lens of risk versus compliance. And it's highly likely that some of these very innovative things will not be compliant. There may not even be an applicable STIG that you can look at to see if it is compliant. So what we look at is the overall risk of that and determine whether the mission necessity of that innovation is greater than the risk that it presents to the network, right? And that's the balancing act that we ultimately come up to. And it's how we allow innovations to happen by looking at overall risk versus just saying you can't do that because it uses Bluetooth. Somebody asked me about this. Can we use Bluetooth? It depends, right? it depends.
Conrad?
That is so awesome to hear because I echo that sentiment. And that gets back to the how do I support the secure execution of mission? That says, let's begin with the innovation that is being leveraged to address a significant need. And instead of it being, well, it doesn't comply with this regulation that was published 10 years ago when this thing wasn't even around, where the risk discussion is what's in play. What are the mitigations that you need to employ in order to facilitate that piece of technology being successfully run, because the benefit needs to outweigh the risk. The benefit, and the timing of things also matter, because I've been on the battlefield and had some folks just throw something over the fence and say, Chief, we're doing this. Protect it. Let us know in the morning how are we going to protect this. All right? So coming from that environment and informing the data or whatever that capability is, that is what's in play. That's the important piece. And one of the good things about what's happening within the Center for Medicaid and Medicare Services, and later on this afternoon, the CIO, Rajiv, is going to be here speaking, but he and his team and Robert Wood, the CISO, have a customer-focused mindset to enable the development and deployment of these capabilities. Their whole focus is, what can we do to remove some of the overhead and those barriers to innovation that happen where they see security as the document burden area that, where everyone goes, I don't want to do that change because it's going to take too long, and a year later you're going to get the device. Mm-hmm. Well, what they're doing is saying, you know what? For development and your coding and your organizations, because CMS is a large federated organization, they are leveraging the CMS cloud. They offer resources to support your deploying your application or system in the CMS cloud. And with that, there's something called rapid ATO. Everyone who has encountered an ATO process know the incredible burden it is. You deploy your system to the CMS cloud. You inherit controls so that 80% of your ATO package is already done the minute that it's deployed there. 80% of the work with documentation you're inheriting. That's a huge deal, because they want the developers and the teams to worry about the coding to deliver the capability versus managing infrastructure, managing security controls, and some of these other things. And because you're deploying it to the CMS cloud, which is also, from the Zero Trust standpoint, the area of focus for the organization, because once the Zero Trust architecture features and capabilities that are deployed there, selecting deployment to the CMS cloud, and every year looking at like the system census, there are more and more systems being deployed to the CMS cloud. The percentage of compliance systems who are protected and are able to deliver services to the customer base increases. And that's a huge deal, a huge deal.
So we're over a year since the executive order on cyber. We now have OMB guidance on cyber. And we just had a great conversation about the future of innovations and things we can bring to bear. But a lot of what that executive order and OMB guidance touches on is legacy systems. So I want to just get the take from everyone down the line. How is your implementation going so far with your Zero Trust, as well as how is that impacting on some of these legacy systems that are very difficult to get into those pillars and ICAM type environments? And I'll start with you, Conrad.
I am in sort of a unique circumstance because I've been on a detail for the past 15 months supporting HHS and their efforts to respond to the President's EO and cybersecurity. Mm-hmm. And I still have my feet in supporting my program at CMS. And with respect to the President's EO and legacy systems, it's a narrative where, from the standpoint of the organization and decision making, and this may sound a little, but from my perspective, legacy systems, you manage the security around it because you're not going to be able to get it into a software-based environment and the like. So efforts should be focused on the systems that are able to support it and new systems. That's why with CMS, they're creating a destination. Those legacy systems, and my system used to be one, and we actually got a contract with GDIT, and I've pushed the we need to be cloud ready, but that needed, an iterative process. And there needs to be enough leadership, focus, and let's just say bravery to be able to say, we'll chart the course to replacing this so that we can do more. And that takes leadership. And fortunately, I've worked with some folks who are very demanding and have pushed us. So that's why my system is in a position where, in terms of the analysis of the Zero Trust pillars, and it's dandy, device, application, network, data, and identity, dandy, that's the acronym we use. All of those areas, we are very mature in quite a number of them. So assessing ourselves, and that would not have been possible if we relied on the status quo and just continued down the path that we had previously.
Yeah, and so I'll start with the fact that Zero Trust is not an application that you buy off the shelf, even though you probably have 5 people a week trying to sell you one. Buy our Zero Trust solution.
Yeah.
It's more like 100.
Yeah. there is no such thing. It's more of a construct. And so specifically from legacy, I'm going to put on my other hat for a second here, because our portfolio within Solution Delivery Division is all the legacy IT systems for the Defense Health Agency. And we use a principle called ROCM. It's rationalization, optimization, cost control, and then modernization. And so you have to look at which of the categories each of those legacy systems fall into. And it's really about, portfolio rationalization at the end of the day. Our large legacy systems are in the process of being sunset. And so for the most part, we are holding where we're at with those, because by the end of 2025, they will all be lights out. And I don't know if anybody saw this, any of the press on this, but we actually turned off the very first CHCS host site out at Madigan back in September. And it's a monumental thing. I don't think I have probably been there for the implementation and ribbon cutting ceremony on about 100 different projects. And I've only ever been to one that we've actually successfully shut off. And so that was a huge deal. So that's number one thing, is turning off the stuff that it's cost prohibitive to actually implement some sort of Zero Trust construct around it. We're also moving towards platform as a service and putting more eggs into those platform baskets, and then using Zero Trust construct around those platforms so that we're not building multiple different things. We're building that for this platform. So we've invested heavily in that. We have just about every modern platform, name a modern platform, we probably have it in that technology stack, like Salesforce, ServiceNow, MuleSoft, OpenText. All of those are in that technology stack underneath there. And so putting your eggs in one basket versus these hard-coded legacy systems that were written in Power Builder, we still have several of them out there, right? And trying to implement Zero Trust around that, good luck, right? And so I concur with the fact that many times we can't directly apply that. We'll use a system that we operate for IDAM, ICAM, called IAS, and put that at the front door versus in the application itself, if we can't actually change that hard-coded application so that at least you can control the identity and role management inside of there from the front end. So I think I've said I could go on for hours about this, because this is our life. But I actually don't. So just so you know, so nobody sends me an email, I do not own Zero Trust at DHA. That's owned by Tony Gilgum. He is the lead for that. He's the chief engineer, and so he actually has the lead for the implementation of Zero Trust at Defense Health Agency.
William? These guys already said everything. No, I'm just kidding. No, within VA, We have our legacy devices is something we're really, really paying attention to, and we're working towards actually having more isolation. I keep mentioning isolation. I talk about zero trust strategies. The way we do it today within VA, and I think it's important for everyone to understand, is we have them isolated. We have them in VLANs, protected by ACLs, what we call access control lists. Right? We have rule sets and policies that circumscribes those isolations to support those devices. But I think it's more important too is, and you mentioned this, is not just, you can't protect those devices. You can't change and modify them. They're old, they're antiquated. A lot of the OSs are, end of life, believe it or not. So what you have to do is you have to encase them. You have to put them in pit environments and make sure you have a secure infrastructure to support those devices. And that's what we have today within the VA. However, we like to move from the ACL and have more rigor around those devices, still isolate them, have them in zone architectures behind firewalls. So that way it'll allow us to take advantage of some of the security solutions, or more of the enterprise security solutions that we have, passive vulnerability scanning, because a lot of the medical devices, you can't do active scanning. In other words, they can't be interrogated. It could cause patient safety. It could be at the detriment of patient safety, or just breaking that device or causing some type of misconfiguration. So we would like to move towards just isolation behind firewalls, being able to take advantage of more of the analytics, taking advantage of some of the vulnerability management activities that we have. But not only just that, make sure we have a solid inventory of the legacy devices. It's very important because prior to, in some cases, depending on how far you go back, maybe there wasn't a good management of inventory. You can't protect what you don't know, right? What you don't know you have. So it's important that you have that solid inventory. And when you have that solid inventory and understand the data, then you can move forward with the proper categorization of those devices and protection therein.
All right. So in our closing minutes, we have about time for one more question. One of the things I'd love to know is, from your perspective, what do you see in the future as both a near challenge as well as something that an innovation that you think will really take off? I'll start with you, Conrad.
This is one of those areas where the organization, looking at, the Colonel talked about creating an environment. At CMS, there is something called the Bat Cave. For those of you who don't know, just Google it. CMS Bat Cave, BATCAV. That the cave stands for Continuous Assessment Verification Engine. And it's an environment that supports DevSecOps so that they're getting services and capabilities that the organization is delivering so that they can focus on the capability that they're trying to present. They can focus their coding on the capability versus the infrastructure and the security of that language, all the assessment that's going in at every turn. So that is one of the things that will get capabilities delivered sooner. And that's a huge deal for us because, again, it's focused on delivering services for the American people.
All right, Colonel Howard.
So my boss's mantra for this is, and his motto is, make IT boring again, if you've ever heard him. So I am going to stick with his mantra here and give a very, very boring answer to this. And it's the fact that cybersecurity is way too expensive right now. And what we're doing is entirely too expensive across the board. So the innovation you're going to see within Defense Health Agency, at least, is doing what risk management framework was designed to do in the first place. The only thing that makes it better than any of the ones before it is the concept of continuous authorization, right? So that you're not every 3 years going back through the ATO process and rebuilding the ATO. So come hell or high water, before I leave next summer or so, when I retire after 31 years, yay me, we will have at least the first systems and enclaves in continuous authorizations. And what that does is it puts money back into the coffers so you can do innovation. Right now we're going broke, right? We're going broke just keeping this stuff scanned, patched, and then every 3 years spending $120,000 to $250,000 going through the A&A process. That's ludicrous. We have 1,600 authorizations. Just do the math on that for a second. 1,600 authorizations times that. That's a lot of stinking money. And if we can take that, invest in our red teams in order to validate the security of those systems and enclaves, if we can take some of that money, invest it back into innovations that actually help us automate portions of the defense of our network through seam source solutions and other augmentation there, that's really where we're going. It's to do some of those very boring blocking and tackling things that'll allow us to get money back in order to do those innovations.
All right, Woody, can you close us out?
Yeah, so you mentioned earlier about services to your customers. Well, we take a lot of pride in the service that we provide our nation's veterans. So it's very important that we are able to allow our healthcare providers to deliver healthcare, right, and quickly and efficiently as possible. So what we're incorporating, and one of the innovations, is making sure that we, instead of trying to go through that ATO process you're talking about, the risk management framework, we're still adopting that risk management framework. But for those Internet of Things, medical devices, special purpose systems, we are going to do assess and incorporate. You're still going to have the same rigor of security. You're going to still have the same reviews, assessment, and analysis on those devices. But since we are already encasing them into a isolated network, circumscribed by security and solutions that analyze that traffic, so we're able to do that assessment and incorporation. So now it doesn't take 180 days or longer, right? We know this. 180 days to go through the risk management framework. We can probably get it done in 30 days or less. So I think that's very important in a healthcare setting where they're really relying on this equipment and these devices.
All right. Well, I'd like to first give an applause for our panelists today. And thank you for all of your leadership. Thank you very much.